Let's go ahead and talk about light and vision. Light and vision. This is your sense of sight. Vision is actually started when you experience an electromagnetic radiation known as light. huh? Electromagnetic radiation is a visible representation of light. Human vision will depend on our receptors for wavelengths of this electromagnetic radiation. And wavelengths come from 400 to 700 nanometers. If it is made out of 400 to 700, our receptors in our retina will pick it up. Some of them are below that, and those are ultraviolet radiation, all right? And some of them are above that, or infrared radiation, huh? And in fact, may not be necessarily our appreciative or appreciated vision. Light causes a photochemical reaction to produce a nerve signal. That reaction is the transduction mechanism. A physical entity like light creating a photochemical reaction with our receptors creates the nerve signal and therefore the transduction mechanism. Very, very amazing. Let's start with the anatomy of the eye. So from the outside, this is the eyebrow, and then you have the actual, this is the left eye. You will see the superior palpebral fissure, which closes because of the facial nerve, can open up because of the oculomotor nerve. You have the palpebral fissure, the lacrimal caruncle, medial and lateral commissure, the sclera, which is the more white part near the cornea, and then the conjunctiva, which leads all the way to the skin. Okay, huh? You will see this sort of boundary where you have a dark area, that's your pupil, but the boundary itself, all the way to the edge of the white part, is actually the iris, which moves. It can uh, be longer, or not really longer, but it can be pulled in by the circular smooth muscles to make this small, which makes a pupil constrict, or it can be pulled by the straight muscles here that makes it dilate even more. All right, I may have to just mention that the tears come from the lacrimal apparatus, which populates or floods the area of the eye, the front of the eye, to make sure it is well lubricated. When we open our eyes, it will be prone to being dry, so our tears normally lubricate them and keep the surface healthy and well lubricated. It is when we look at cell phones and playing games sometimes, the kids playing games, they tend to hold that natural thinking, which then makes them feel dry and ends up in them scratching it, and a possible infection can get in. See, so in reality, if we are going to use our eyes, especially at work, we should probably best put a eye lubricant for it to survive better through our work. That helps to keep the eyes lubricated, even we try to focus on the computer or focus on our work and sometimes prevent the normal blinking. Let's have a good anatomy of the eye. Inside, you'll have this lacrimal gland, right, which floods the area, lubricating the area. They will drain into the nasolacrimal duct. This lacrimal sac, which continues to the nasolacrimal duct, actually opens in the inferior meatus. It adds to the humidity of the nasal cavity. There will be cases when a person will have dry eyes, and we either put some external lubricating fluid, or sometimes the ophthalmologist may even put a temporary seal on that opening and see if this will cure the situation. If it does, and it starts to become more lubricated, then that temporary seal can be taken out. There are cases when we have to actually seal that because you're not producing a lot of fluid and you actually need it on a more continuous basis. This picture of the eye shows the muscles that are responsible for the eye movement. Here you will see the lateral rectus, you will see the superior rectus, you will see the inferior rectus. And over on this side, you also see the levator palpebrae. Huh? These are muscles of the eye and responsible for moving the eye. For the eye muscles, I'll let you read this, but I'll refer to it on the illustration following this. You see the eye muscles here. Here's an actual picture. Let me start with this. If you see this eye, all right, this is actually your right eye inside the orbit. You will have the rectus means straight muscle. So rectus, huh? This is the lateral rectus. This is the medial rectus. This is the superior rectus. This is the inferior rectus, okay? So when the lateral rectus contracts, then it makes the eye look to the lateral, to the side. When the medial rectus contracts, it makes the eye look to the medial side towards the nose. And so the same thing with the superior and inferior, it makes you look in those directions. There is another muscle here, the inferior oblique. All right, this is a bag of odds, huh? Although it says inferior, it actually makes the eye look towards here, the superolateral. It will my eyeball turn that it will end up looking at the superolateral. All right, and this superior oblique, when it contracts, it makes the eye look in the inferolateral. See, it's opposite, huh? Makes the eye look in the inferolateral. Now, this superior oblique is amazing because it passes through this, uh, we call this like a pulley, see, a trochlea. And then the muscle inserts there and then goes backwards. And this is one of the wonders of the human body. Who would be putting that through there, even through embryonic development? How would it ever know to even pass by there? And then it's already made when you are born. See how amazing. Now, I will also, I guess, the good designer above, right? Now, I would also mention that there will be some compensating movement here. If this is on the right eye, so if you have the left eye on the other side, then you will have the opposite. Imagine this eye on the opposite side. You will have the medial rectus also like you have here, and you will have the lateral rectus like you have here. Okay, so when you make both eyes look to the right, well, what would happen is the lateral rectus will contract, but the medial rectus will be passive. It will not contract, allowing the lateral rectus to make the eye movement to the right side. However, the left eye, because we're looking to the right side, the medial rectus will contract, while the lateral rectus of the left eye will be passive or relaxed. Therefore, both eyes will end up looking to the right. Okay, huh? So that's an important mechanism we should remember. If you are moving the both eyes to the left, then the medial rectus of the right eye will contract. The lateral rectus of the right eye will be passive. On the right, on the left eye, the lateral rectus will contract. The medial rectus will be passive, and therefore you're able to move to the left eye or to the left side. Same thing with superior and inferior. You activate the superior, both eyes go up. Activate the inferior, both eyes go down. In the clinics, we do this by using an object where both eyes will focus, and we move it to the cardinal signs. We go from the center upwards, obliquely to the left, downwards to the right, and then we also move it on the opposite side. We move it to the left, we move it to the right, and move it up and down. Very important, remember, do not forget about the subject. You can't just move the focused object as fast as you want. No, imagine the subject. You should move it at a speed where the subject can follow it, right? Be aware of that. Don't forget that. All right, so by doing that, the muscles are able to move the eye in the right movement and direction. Now, very important also is learn and know what nerves move these muscles. Okay, three cranial nerves are involved: oculomotor, trochlear, and abducens. The easiest way to remember this is to start with the least. Start with the abducens. Remember that it powers or innervates the lateral rectus. So abducens cranial nerve number 6 moves the lateral rectus. I remember it for LA. LA, lateral abducens. See? How about the oculomotor? Oculomotor innervates the superior oblique. So I remember SO4, sulfate in chemistry. Superior oblique number 4, which is your cranial nerve number 4, trochlear nerve. Now, after remembering those two cranial nerves, it's all easy. You know why? Because all of the other muscles, superior oblique, superior rectus, inferior rectus, medial rectus, inferior oblique, are all innervated by the oculomotor nerve. So you see, remembering the least, abducens and the trochlear nerve makes you be able to remember everything because all the rest are by the oculomotor nerve. Okay? Here's the eyeball, anatomy of it. Huh? Let's begin with the parts of it. I'll give you a few seconds to be familiar with it. Go ahead and look through all around, huh? Through all the so what we got? We got the sclera, which is actually coming from the front all the way to around the eye, and in fact, even through the optic nerve, covering the optic nerve. Then we got the choroid, next layer after the sclera, and the retina. The retina, if you imagine it, the optic nerve has a very sensitive nerve. Imagine it opening up, opening up. So therefore, the retina is actually a part of the optic nerve. It's actually the most inside, most sensitive part of the optic nerve. That is why it is so sensitive. Then you have if you have your vision or your line of sight, it will go through the center of the eyeball, excuse me, to the center of the eyeball, and it will land in the center of the retina, of the wall itself, straight from the center. Where it lands is actually your fovea centralis, and the area where the fovea centralis is, we call it the macula lutea. Okay, this is the optic disc where the optic nerve exits. This is the optic nerve, and through the middle you have the central artery and vein. Towards the front, you will have the cornea, okay, and then you will have the iris. Note that the iris has circular muscles that when it contracts, it helps to pull and make this narrower, right, the opening. It also has longitudinal straight muscles, which then retract, and therefore the edges become closer to the peripheral, making the opening be bigger. Right, the opening itself is what we call the pupil. so, so it was dilated or constricted. Now, this iris serves as a boundary between two chambers. You will now have the anterior chamber And then you'll also have the posterior chamber right behind the iris. So anything in front of the iris is anterior chamber. Anything behind it is posterior chamber. Another organ behind the iris is the lens. This lens is crystal clear to begin with, huh? And then behind that lens is actually your ora serrata. There's another capsule that maintains the position of the lens in place. You also have this hyaloid canal leading to the center of the optic nerve. Okay. Now, this anterior chamber, right, is filled with aqueous humor. This area of the ciliary body, right, has suspensory ligaments which hold the lens in place. But the ciliary body is responsible for secreting fluid we know as aqueous humor. This fluid floods the posterior chamber and then leaks into the anterior chamber where it fills the anterior chamber. Then it exits through the side. On the peripheral, you will have canals of Schlemm. Canals of Schlemm let the fluid drain out, which is ultimately going to be draining into the venous system. Okay, so the right amount of pressure is maintained, and then the excess fluid is dissipated through the venous system by way of the canals. All right, so this is the normal anatomy of the eye. Okay, now let me start discussing what happens if the changes here happen and you end with some abnormality. Okay, number one is the cornea. If this cornea, which is supposed to be perfectly rounded, ends up to be flat in the middle, rounded on the side, or even rounded on one side and flat on this either opposite side, you will have a condition called astigmatism. Astigmatism. From the word itself, a means without, stigma means a sign, and ism means uh, pertaining to. So it would read condition without sign, where sign and plural of sign is stigmata. So astigmatism is condition without sign. And that happens because in a normal cornea, all rays, all right, all focal line will focus on the fovea centralis. Even on the curved part of the cornea, it will it will reflect and then center on the fovea centralis. So all of them will reflect and center there. Okay, so you have a sign or an image. But with astigmatism, the curved sign throws a different angle. It may not reach the fovea centralis. It may be here. The flat sign may be here. So it's different uh, positions that are met and therefore will not constitute one image. So that's why it's astigmatism, no sign or image. Okay, so that's the first part. Stigmatism. You can correct it by LASIK. LASIK will reshape that to the proper curvature. Okay, depending on what the measurements will be. The next one is the the lens. It's crystal clear to begin with, and it's actually malleable. The suspensory ligaments can make this become more stubby or thick, which is needed for near vision, or it can pull it, resulting in a flatter disc. All this is changing depending on where you focus, and it's very durable and malleable, meaning it will change during the uh, early years. Now, the malleability will slowly change and become harder to be thick or thin. When that happens, it is when a person, usually after the age of 40, can't see any more sharp on the near focus and has to move uh, a book further away and be and hey, okay, that's where it's comfortable to read. So the focus now, since this is not so changeable or malleable, you'll have to adjust on your reading distance. Right? When you reach that stage, that's what we call your presbyopia. 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 Now, as it continues on, this will further get more thicker, more sclerotic or harder, and more fuzzier. Okay, and eventually will end up decreasing your visual acuity to maybe more than 20/40. At that point, this has ended into a condition called cataract, and this has hardened and sclerosed. At the same time, it's not passing light clearly. In the olden days, we would incise here and get the whole lens out, put it in a sample bottle, and show it to the patient. And then we had to suture here. But modern cataract surgery does not suture anymore unless there's a major thing that happened. We actually can go in and just a small slit, okay, just a small slit, be able to insert a syringe-like equipment, all right, and make this emulsify, all right. When it's emulsified, almost like in pieces, then we can vacuum it out, really, kind of suck it out the pieces. So you don't really get the whole lens already. It's been put into pieces. Now it will leave us an empty area here, and then out of that syringe also, we can insert a lens. It's actually folded. Amazing. It's folded to fit inside that big syringe, a big sorry, big needle. And when you push that, the needle then delivers the folded lens inside. It will then unfold and we can position it properly in the center. Imagine the cover of the windshield, the one that you can fold on both hands and then it gets smaller. That's basically what it is. The idea, it will unfold and then you can have the actual lens in the center. That lens is dependent on the person's optical measurements, and therefore they will be able to see even without glasses. Although near readers are still unavoidable because we don't change the muscles, and this lens is not conforming anymore. Okay, so there you go. That's your cataract. Another condition, when fluid is pushed out here and it fills the posterior chamber and the anterior chamber, pressure will build up here. A normal pressure, and you should put this in your bag of norms, is about 10 to 20 millimeter mercury. Millimeter mercury. And that normal IOP, another abbreviation you should write, intraocular pressure, should be maintained. A person who increases that pressure by either having a blockage here and therefore fluid won't go out will end up in glaucoma. 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 And this could be also familial. It happens in the family. So if one family member has that, then it's best to also be preventive and have this measured early on. It could also be acute glaucoma when an impact hits here and pushes the eyeball to the back. Could be open angle glaucoma, actually close angle glaucoma. And then this will be a little bit more tighter instead of this wide, and therefore the outlet of fluid is blocked and will also increase the pressure. Fluid that is kept here will put the pressure on the lens, And that increase in pressure will put pressure on the vitreous humor. This vitreous humor is like a jelly substance, a jelly-like substance that fills the whole area here. That would press on the retina and actually press on the optic nerve. So being pushed here, this material or nerve tissue that's caught in between this and there's a bone here, huh? So pressure there slowly kills the nerves of the optic nerve. And those nerves are the one responsible for the retina. Therefore, prolonged pressure there will lead and can block this situation. What would happen is you will end up losing your peripheral vision. Some people don't notice it until a time when they feel like they're looking through a tunnel and they now have tunnel vision. But by that time, the nerves that have been impinged may have already died, right? And that condition may not get any better. So the patient would say, there's fuzziness on the outside, but clear in the middle. Fuzziness on the outside, clear in the middle is a sign of glaucoma. Okay, there you go. So you can add that condition in our list, glaucoma. Of course, we can have ways to treat that. We can control that pharmacologically by controlling the fluid that's being produced, or we can sometimes add tubes here so we can release the pressure, right? And we got to monitor this. In fact, we subject the patient to a test where you put the chin in, right? And then you have this clicker, and they look inside the field, and every time they see a flash, they click. In the end, you will be able to map the extent of the visual field of that eye. We do it on both eyes, and then we use this as a basis. Whatever is mapped out will be checked again, let's say after 6 months. So if we can see if there's any decrease in the visual field, okay? It's a very, very important test. We could also do this um, in the clinics, okay, by checking the area where the by using a manual field test, which measures the angle of the that the eye can see. Okay, here's another condition. Like we said that the line of sight will end up right in the middle and then focus at the fovea centralis or the macula lutea. Now, this constant focusing can do some wear and tear on that surface. In fact, some individuals also may become may be a familial disorder, have a tendency to degenerate faster than regular individuals. Right? They will incur a condition called macular degeneration. Right? And when it gets severe enough, you'll have fuzziness right at the center of your visual field. And sometimes they describe this as fuzziness in the center, but clear on the side. If you think about it, it's opposite that of the description for glaucoma. When glaucoma, there's clear on the center, fuzziness on the sides. So this macular degeneration will eventually end up making your vision fuzzy right from the center going outside. Right? It's a downhill degeneration, but we'll try to, at the best, do everything we can. Good health, good rest, some items you can take orally, but eventually this will get worse. So it's important to monitor it at the earliest part and be aware of the situation. So there's your macular degeneration, huh? Another condition we should discuss here is in diabetes, the quality of the blood becomes a little bit more viscous, and the blood vessels also get tighter, huh? Organs like the eyeball, the kidney, the skin, areas where there are small arteries are greatly affected by this condition. And so in the eye, the blood vessels get more sclerotic or thick or constricted, while the blood becomes a little bit more thicker. So, not a good combination. In fact, that would make us unable to penetrate some areas of the eye. Okay? And so, what the body will do, it will compensate and try to make blood perfuse through the retina in layers. uh, and sometimes the layers reach the area of the retina, and so it's able to perfuse, nourish that area, also get the waste product from that area. Now, since these are not actual vessels, they can get separated. In fact, as you move, and this jelly substance also moves with your locomotion, when you're moving around, it can actually be one of the sources where the pull is going to come from. So as it moves, it actually can help detach the retina by separating the layers where the blood flow is. And this can lead to retinal detachment. Retinal detachment. The patient will complain of like a curtain cutting on their vision, a dark curtain cutting on their vision. And they may also complain of uh, floaters, right? Floaters. When these two happens at the same time, abruptly, this may be a sign of retinal detachment. And you have to send your patient to the ophthalmologist, and specifically the one who is a retinal specialist, where they can apply cold laser to buckle up, to sort of reattach the areas before they completely detach. If they completely detach, we'll end up in blindness. So this can happen in a day. We'll make sure that we get them to the retinal specialist, buckle this up, and then help the retina heal. Okay? But if you think about it, in order to treat this problem, you got to go to the very origin of it, which is the diabetic condition. So we make sure the patient is controlled, controlled, and the diabetes is uh, not made to its worst condition. The sugar should be monitored. Medications can be added in order to make this happen. So this is diabetic retinopathy. Diabetic retinopathy. Okay. You can also have other conditions. Fungus can get into the eye. Some parasites can also get into the eye. So those are other not as common, but conditions that can also happen to the eye. The vitreous humor, like we said, is a jelly substance that keeps that's in this area behind the lens and makes the eyeball actually stay rounded. The vitreous humor exerts enough pressure to keep this rounded, right? Very important, because if this is not rounded and the pressure is less, like a deflated ball, imagine how hard it is for the eye muscles to coordinate to move it when one eyeball is not moving so much, because it's not as sort of intact or solid. So that's also another disease that can happen here. Hypertension can also be seen through ophthalmoscope, where you can view the vessels, right? There are signs in there that can relate to a hypertensive situation. All right, so many diseases we were able to discuss. All right, we mentioned this. Okay, and we mentioned that also. And this is also another picture showing the presence of fluid and how it is expressed through the iris into the scleral venous sinuses or canals of Schlemm, which can, this picture also shows you how the pressure is developed there and here. This is also a description of how glaucoma will set in. Okay, we discussed this. Glaucoma is also known as increased pressure in the eye. Meanwhile, cataract is also known as painless progressive loss of vision. painless progressive loss of vision. All right, moving on. The neural components include, excuse me, the retina and the optic nerve. All right, the retina, like we know, is part of the optic nerve, okay, and is pressed against the rear by the vitreous humor. And we can examine it and find the fovea centralis in it and the blood vessels that populate the area. And this is part of a regular eye exam, huh? By the way, for the eye exam, your optometrist is a doctor who can visually do physical exam on the eye and also diagnose diseases. They refer to the MD. Huh? Optometrist is DO. No, it's actually OD, Doctor of Optometry. DO is Doctor of Osteopathy. Now, the optometrist refers to the MD, which is the ophthalmologist. Huh? Remember, it's OPTHAL, huh? Not not without the H. It's OPTHAL, ophthalmologist, who can confirm the diagnosis and could also initiate some treatment, surgical or medical treatment. Huh? The ophthalmologist can perform surgical procedures like cataract, corneal transplants, corneal corrections, even taking out the eye, as in enucleation. The optometrists usually do not do surgical procedures. Okay, and within the ophthalmologist profession, there still are different subspecialties: retinal specialist, corneal specialist, and so on and so forth. This is what you see using the ophthalmoscope. You can see the center there where the optic nerve is. Huh? That's your blind spot or your optic disc. This is your fovea, and these are the blood vessels. In the artist rendition, it looks like this. Huh? This is an artist rendition, not an actual patient. But you see the optic nerve there, and that's where the vessels come from. This is also called your blind spot, by the way. Huh? That's your fovea centralis macula lutea. You will experience this blind spot if you look at this picture right here. As you close the right eye, looking at this with the left eye, focusing on that X. As you bring it closer, the axis goes towards the optic nerve. From here, it will go towards the optic nerve. When it passes the optic nerve, the brain can't see anything, so it just uses whatever's dominant to cover that space where it can't see anything. We call it brain mapping. Uh, when that happens, it fills it with this green line also, and therefore you would say, "Hey, I saw the whole green line, but not the red spot." So that's what happens. You pass through the optic nerve area, which is the blind spot, and then the brain fills it in. Visual filling is what we say. Huh? All right. You can experiment on it by there's a page in your workbook, and you can bring it forward and backward to experience this. As light passes through the lens, it forms an inverted image on the retina. The iris diameter controls the amount of light, and it constricts if there's too much light. It dilates if there's less light. Huh? Also, this dilation and constriction can be affected by the autonomic nervous system. It would be kept constricted by the parasympathetic, but the sympathetic widens it because it wants to see danger that's coming in. Okay, huh? And that's how you measure it. You can test it through the clinicals also by introducing light. If you're in a dark room and you introduce light, it will make the pupils constrict. And we call it photopupillary reflex because of the light. You can also check consensual reflex. The same procedure, let's say start from the right eye it will make the right eye constrict. But then you have to move to the left eye real quick, and you should see it also constricted. If it's positively constricted, then we say there is a consensual light reflex. What the right eye experiences, the left eye consents to it and and constricts as well. Now you should also test it vice versa, meaning coming from the other side, left side, test the left eye and then test the right eye. They should both constrict. If one eye does not work with the other eye, then you have an abnormal situation. And somewhere inside the brain, there's a nerve that does not do what it's supposed to do, and there's a asymmetry, or rather than asymmetry, there's uh, a miscommunication between the two eyes. Should be followed up. It could be a minor situation or a major situation going on. Refraction is light rays coming in, and on the sides of the cornea, it should bend. All of them are supposed to conglomerate or focus at the fovea centralis. Huh? But as it goes in, refraction can experience changes as it goes to the different layers towards the eye. Huh? As we move in, the greater the refractive index, the greater the angle of incidence and more refraction is needed. So here you see a lens. If it's straight perpendicular to the lens, it's going to go in a straight line. But if it's oblique, then it will bend a little bit before it goes through that same situation. So there's some bending or changing, but not too much, no? Light passing through the center of the cornea is not bent. Off center, they will bend toward the center. The aqueous humor do not greatly alter the path. All this bending will focus on the fovea centralis. See that? All this being right straight, and then it bends where the cornea is bended or bent rather. They will all focus on that fovea centralis. Huh? If they all focus there, then you got a nice, perfect 20/20, maybe even better vision. Huh? Again, if the cornea is um, irregular, as in astigmatism, these rays will not necessarily end up there. They may end in other parts. Therefore, you have different uh, distances in the retina. It will be a blurred vision. We need to have a lens here that will compensate. If it's rounded, the lens will be a little bit flat. If it's flat here, the lens will be a little bit rounded depending on which angle it should be set to compensate. If it's compensated, then you'll have a glass here that has all the corrections. Okay? All right. So this is refraction. The near response is when the eyes relax and focus on an object, light rays come in and they parallel and they come closer, huh? Emetropia is the normal state of the eye, and the light rays focus on the specific point in the retina. There's no changing in the pathway. Now, if you have an object and bring it closer to both eyes, they will converge the eye, and therefore the visual axis is toward the objects. That's your near response. It will come to a point when it's getting fuzzy, and that's your maximum near response. Huh? Then you can bring it outwards again. Uh, like I said, the eyes accommodate, they change the curvature of the lens and enable you to focus. It becomes thicker when you're focusing on an object that's near, and it becomes thinner when your object is further away. Okay, see that? Thick and thin. And the lenses usually stay thicker when you're looking at a certain object up close. Okay, as you see here, thick and then thin. All right, and therefore you're able to adapt to the visual axis. This changing again, thick and thin will end up not changing too much. not changing to thick, not changing to thin. And that's like what I said, approaching the the age of presbyopia. Here it shows you the lens, okay, in different patterns. You have the actual eye. Here's a normal eye where the focus of the rays end up in the retinal wall, and therefore your vision is 20/20 sharp. This is where the focal plane is, the focus of the image. If the eyeball becomes shorter in length, that's what happens here, then the focus actually is beyond the eyeball. The focal plane is basically beyond the eyeball. And you will have in this part, instead of a meeting of all rays here, you will actually have a bigger spot here, which is blurry. Condition where the eyeball is shorter than normal is what you call your farsightedness, or farsighted. We also call it hyperopia. So we need to add a lens. In fact, we add a concave lens in order to bring the image a little bit more sooner and land on the retinal wall. When you do that, you will be able to see better and at 20/20, huh? So in a short eyeball, which is a far-sighted eyeball, we use concave lens. Meanwhile, the eyeball can also be longer, as in this case. Longer eyeball will make you also blurry because the focal length is in front of the retina. So when it reflects back, you have a blurred image here on the retina. The image, which is now in front, has to be pushed backwards. And for that, you use a convex lens. A convex lens makes the image go further and it reaches the retinal wall. That's how we are able to measure and know if the person is nearsighted or farsighted. Huh? Right. The doctor has equipments that he can wear or and use on his head, and then he has this prism. Even if he doesn't have any inputs from the patient, he is able to know if the patient is nearsighted or farsighted already. Okay. By the way, nearsighted is myopia. Maybe you remember NM, New Mexico. Nearsighted, myopia. You'd also remember that myopia, M, nearsighted, N, are letters close to each other in the alphabet, near to each other. See, huh? If you're nearsighted, you are more comfortable seeing up close, really up close, within a palm's length or less. And you are unable or not comfortable to read items in the distance, right? Huh? Your optic measurements are usually minuses, -1, 1.5, -2. LASIK can fix until to a certain minus level, and beyond that, it'll be hard to change it or reshape the cornea. On the other hand, if you are hyperopic or farsighted, you will be needing lenses that are positives, +1, +1.5, and so on and so forth. Therefore, you're able to compensate and read as if you are 20/20 in vision. Okay? Now, as we move on, you will find out that the retina is able to pick up vision because of transduction. Okay? Transduction happens when the retina converts light energy into action potential. The light energy, the electromagnetic energy, will then reflect into the retinal wall. On the retinal wall are pigment epithelium and neural components. This will have photoreceptors. And when you say photoreceptors, those are your rod cells, cone cells, and ganglion cells. But rod cells and cone cells are able to produce visual images. You'll also have bipolar cells and ganglion cells. Remember our lecture on neurons, where the most popular is multipolar cells. Um, the bipolar cells, we said, are found in the vision mechanism. Ganglion cells are largest of the neurons and are able to guard the action potential. So you'll have light absorbing cells, rods and cone cells, where the rod cells are used for night vision and produce a scotopic, all right, gray vision or monochromatic shades of gray. Huh? You will have an outer segment filled with modified cilium and an inner segment filled with organelles in order to produce this vision. Cone cells are responsible for color and therefore will give you a photopic vision. It's best also in known to be used more in day vision where there's light. Huh? The outer segment tapers to a point and the disc have plasma membrane enfoldings. Right? So rods and cone cells, huh? They look literally like rods, see, and also look like cone, huh? These cells have this inner segment for the rods, outer segments, and they have their cell bodies. Same with the cone cells, you have the stalk of it, mitochondria level, also in the rod cell, and then the nucleus. And then at the end, they have their synaptic vesicles, which is embedded in the uh, retina. So this you will have rod cells, cone cells in the pigment epithelium, bipolar cells, ganglion cells, huh? And they look like this, almost like layered cake, if you think about it. But this would have your ganglion cells, your bipolar cells, rod and cone cells, and then your pigment. This is the sclera. Remember, the sclera is the one that surrounds the whole eyeball. So if you're looking at the retinal pigment, this is the front. This is vitreous humor in this area here, huh? And this is the whole thickness of the retina. This was just an enlarged picture, but the retina, which is usually looking really small, actually can be divided into this many layers. Huh? Light comes in and then penetrates the whole thickness and then starts with the choroid where you see some pigment epithelium will react to it and start the cascade of events leading to production of ganglion cells. Okay, so we can view an image. There's about 130 million rods and only 6.5 million cones. Huh? 1.2 million nerve fibers in the optic nerve can exist. Neuronal convergence helps to process the retina as it sends signals to the brain. Huh? Multiple rod or cone cells synapse on one bipolar cells and multiple bipolar synapse on a ganglion cell. So in the artist rendition, you can see the area of the pigment epithelium where the cone and rod cells are embedded. And when light goes in, it makes the cone and rod cells release their pigment epithelium, their pigments, and then that expresses reaction in the actual cone and cells, and they will react with the bipolar cells, and the bipolar cells will react with the ganglion cells, uh, showing the activation of action potential. And therefore, vision is created because the action potential now is a language that the brain understands. So this whole mechanism is a transduction mechanism of the eye. Huh? The light reacts with the rod and cone cells. Rod and cone cells react, and then will trigger the bipolar cells and the ganglion cells producing the actual signals. Huh? But there's a method to this, which we will discuss. There's also horizontal cells and amacrine cells found in this layer, which helps to focus and create the signal. Rod contain rhodopsin, which is made up of opsin and the retinol, which is a derivative of vitamin A. Huh? This will now help the rods to um, produce the image. Cone cells have photopsin, which is also considered as an important mechanism for the production of light. Say this is the rod cell, you can get that enlarged and you will see it's made out of disc. Huh? If you get one disc, that layer is similar to the layer of our cell membrane, right? Huh? This is a phospholipid layer. But you have this protein inside that helps to create these changes. It will, okay, in the light, it will change the rhodopsin, and the retinal is bent. We call it cisretinal. That in the light, the first in the dark, huh? The retinal is bent, and the retinal and opsin are together. In light, the retinal molecule straightens, becomes retinal, and dissociates, and it will start the bleaching or using the pigment. Then it recreates itself, it resets, and then it's ready to be used again. Huh? Cones also react that way, creating the changes. So again, if in the dark it has this bent retinal and exposed to light, it bleaches itself, creating a straight moiety or protein. Then it goes to load up again in the pigment epithelium, and it's ready to bend again, bend again when it's exposed to light. This whole thing can repeat itself where the cell replenishes through the pigment epithelium. Here's the full mechanism of this. Huh? Let's say you have this rod cell, okay, and you are not exposed to light. When you are not exposed to the light, the rod cell will secrete your glutamate. Now, glutamate is usually an excitatory neurotransmitter, but you need to realize that no matter what the neurotransmitter is, the reaction of the receptor is what's important. If glutamate is an excitatory neurotransmitter and the receptor is excitatory, then you will have an excitation and the creation of potential. But if the receptor is an inhibitory, even if the neurotransmitter is excitatory, if the effect on the cell is to inhibit, which happens in this case, the cell, the bipolar cell here in particular, will not get excited. In fact, it will not react with the ganglion cells, and therefore no signal is produced. And the brain sees it as no image, it's like negative. And what it is, what would happen is there's no action potential produced, so you actually don't make up an image. And that's basically what it is because it's dark. See? Now, if it's exposed to light, the rod cell will not, okay, will not release glutamate. And since no glutamate is released, the bipolar cells don't feel inhibited. And the bipolar cells will actually stimulate the ganglion cells. And when the ganglion cells are stimulated, it sends an optic nerve signal to the brain. And whatever it sent, the image is now created in the brain. Right? Huh? There you go. So again, with exposure to light, the rod cell will not release glutamate, which then makes the bipolars release or stimulate the ganglion cells, and you end up with an image. If there's no image, the bipolar cells releases glutamate, which actually inhibits the bipolar cells and therefore not stimulate the ganglion cells and therefore not result in an image. That's why there's no image. Huh? All right. This whole mechanism is the transduction of vision, huh? How vision is produced, how light as a physical entity becomes a nerve signal for the brain to understand. Okay, huh? In the dark, the rod steadily releases neurotransmitter, and the whole, like we described, the bipolar cells don't react, and there's no signal to the ganglion cells. And opposite happens when there's light. The rod cells do not secrete glutamate, and the bipolar cells get excited and they react with the ganglion cells, and an action potential is produced. Okay, huh? Light and dark adaptation is when the pupils constrict or dilate, and it makes it an instant situation. For example, in a lighted room, okay, and you see the colors of the room. When the light is turned off, you see darkness, and at that moment you'll see flashes of green and red. That doesn't mean that the cone cells are working. Really, what it is those are the last amount of pigment that the cone cells have used up. In fact, after that, darkness will ensue, right? Huh? Darkness. And then suddenly, the rod cells will start working and dominate the picture, and you will see some images around the room. And these are actually shades of gray. At this point, the rod cells are not working at this moment, and therefore giving you those images, huh? More of shades of gray. The duplicity explains why we have both rod and cone cells. Both receptors add to our ability to see uh, colored and shades of gray, huh? It helps a lot in our ability to make a vision. A lot of rod cells are connecting with the ganglion cells. A lot of rod cells are connecting with the bipolar cells, but with only one bipolar cell. See, a lot of rod cells to only one bipolar cells. A lot of bipolar cells to only one ganglion cell. So that's why it's more of shades of gray. While in cone cells, look, one cone cell is to one bipolar cell is to one ganglion. See? So each cone cell has a direct line to the brain. Right? So this is comparing it. This is like your tube type TV to a 4K. See, because they got their own line to the brain, which is okay because remember they're less in number, so that makes it more distinct, huh? While in the rods, they are made to be more of scotopic vision rather than photopic, that of the cone cells. Okay, and rod cells are usually more sensitive, and they are usually on the edges of the retina. Okay, they are more into the shades of gray rather than detailed images. The fovea contains only 4,000 tiny cone cells, while the rod cells are more on the outside. Okay, there's three types of cone cells, by the way. Huh? Remember that the cone cells are supposed to be receptors for light, and light is expressed in wavelengths. Now, the cone cells will have specific capabilities that can absorb or be sensitive to certain amounts of wavelengths. You have cone cells that are for short wavelengths, and you have cone cells for medium wavelength and long wavelength, respectively, depending on the wavelength, huh, for nano, as they are perceived by the cone cells. So if this is the array of vision or array of colors, and these colors are measured in wavelengths, then you can have an actual classification here. For example, your wavelength that are 400 to 4, maybe 450, are best captured by the short wavelength. Huh? You have the cone cells that are best for short wavelengths. But as the wavelengths get bigger, 500, 550, they're best captured by the medium cone wavelength, huh? That can capture that medium range, right? Long range or long wavelengths capture more of the middle going towards the maximum, right? For example, red is in the 675 wavelength nanometers, huh? So only the uh, low, the long cone wavelength, huh? Wavelength that measures a long range, long wavelength. Remember, you have short, medium, and long wavelength. They are the one who can receive the reds. And you see the reds, huh? All the way to 700 even, the average being 675, the peak of it. So therefore, you're able to capture the reds, huh? So depending on the wavelength, the specific cone cells will be assigned to them. Now, if you do not have the cone cells, then you will miss that color. So if you are not having long wavelength capable cone cells, then you will be colorblind to red. All right, see, huh? So whichever cone cell you're missing, the wavelength of the colors that are going to be falling into that type of cone cell will be the one you're missing, and you will be colorblind to it. Okay, so there you go. Color blindness may also be familial, or they can be um, through your um, development as an embryo. Now, to test if we have cone cells are working or not, okay, most common color blindness is red-green color blindness. You don't have the long or medium wavelength cones. It happens in 8% of males and 0.5% of females. So it's sex linked. Now, in order to test if we have all the cone cells intact, you have what we call the Ishihara plates or the Ishihara book, where you have a lot of colors in small specks of circles, and you're supposed to see this 2, 4, or 24 because they're in green versus that of the red or orange hue. If you do not see that 24, that image inside, I think it's 21, I not 24, then you are colorblind for that greenish, light dark green color. Okay, and you'll have about 10 plates in the Ishihara test where you're supposed to get at least 8, huh? Lower than that, that warrants further examination, and they might discover that you have some missing cone cells. Now, when you focus on an object and that object is either in the center with overlapping visual fields, this is giving you or will give you stereoscopic vision. In panoramic vision, you go from one side to the other, while in stereoscopic vision, you just are at center, huh? Okay. Now, if we go to the visual image, you can see that if you focus on this side, the eyes bend towards the inside more, and this side, middle part, and then on the far side. And on both movements, the eyeball will try to connect and compensate. All right, now, as far as the pathway is concerned, the bipolar cells of the retina are the first order neuron. Then the retinal ganglion cells are innervated and they make the second order neuron. The axons form the optic nerve, right? The two optic nerves left and combine to form the optic chiasm. Half the fibers cross over, half goes to the same side. and they pass through the cerebral hemisphere, and they reach the occipital lobe. The right cerebral hemisphere sees object in the left visual field, and their images fall on the right half of the retina. The left cerebral hemisphere sees object on the right visual field. Each side of the brain sees what is on the other side and will control the limbs also on the opposite side. The optic tract passes to the lateral around the hypothalamus, and they end up in the lateral geniculate nucleus of the thalamus. From here, third order neurons go up and make optic radiation into the white matter of the cerebrum. They will project to the primary visual cortex of the occipital lobe and therefore give us the visual sensation. One of the fibers will reach the superior colliculi, which will then coordinate with the tectospinal tract to make the necessary neck movements if we were to follow an object moving at a certain direction. Follow with our eyes. So as you see here, the optic nerve will have radiations. They will then cusate or form the optic chiasm. Half of the optic nerve fibers cross to the other side, while another half stays on the same side and therefore deliver also a piece of the vision to the occipital lobe. Usually, a fourth of the vision to the occipital lobe on both the uh, fibers that cross over and the fibers that stay on the same side. Same thing happens on the right side. Some fibers cross over, some fibers stay on one side. Now, this is the peripheral field, total peripheral field of the patient. Each eye, if you make a line straight at the center, will have your angle A and angle B. That's of one of the left eye. If you see the yellow map here and make a straight line, you will have angle C and angle D from the middle to this part here. So you see, part of the blue vision intersects with the yellow vision, and you call these your overlapping angles, B and D. And this is your vision that you usually abide to when you are looking at an object or forward vision. This is your uh, combined angles. Now, your peripheral vision is what's left of the rest. That would be your part of your angle A and your angle C. If you want the total peripheral field, you really just have to add the angle A and angle C. Okay, and that will give you your total peripheral field. All right. Now in glaucoma, you will lose these peripheral areas, and your vision gets narrower and narrower. So angle A and C are affected. In macular degeneration, since it's happening in the center, all angles are affected. A, B, okay, C is also affected, and D is also affected. So all angles are affected. All right, that ends the lecture on chapter 16, which had the sensory, both general and special sensory. Okay, amazing chapter, which gives us the sensory that is general and also the special senses. Remember, we discussed uh, the sense of taste, the sense of smell, sense of balance and hearing, and sense of vision. Five of those. Let's show some sample questions here. Tell me if it's sensory or general. Sense of touch. All right, that would be general, right? Um, olfactory nerves. sense of smell, right? Cone cells, sense of vision or sight. Crista ampularis, sense of balance. Okay. Um, rods and cone cells used for night vision. Rod cells has photopic vision between rod and cone cells. Cone cells. Okay. Which of them has scotopic vision, rod or cone cells? Rod cells. Tell me if it's near or far-sighted. Uses concave lens for correction. All right, far-sighted. Remember FX, far-sighted. Con. Oh wait a minute. Convex lens, huh? If you use convex lens, you are far-sighted. Okay, huh? Uh, so nearsighted uses concave lens. Okay, huh? That's corrected there. Now, which one is myopic, far or nearsighted? Nearsighted, huh? Myopic. Which one has a shorter eyeball? Farsighted or nearsighted patient? All right, it's a shorter eyeball, farsighted. Shorter eyeball, longer eyeball, nearsighted. Okay, which farsighted or nearsighted? Which of them has the focal plane happening before the retina or happens first before the retina? It is nearsighted because you have a longer eyeball. The focal plane of the farsighted individual happens after the eyeball because it's a shorter eyeball. Okay? All right. Painless progressive loss of vision is glaucoma or cataract. It is cataract, painless progressive loss of vision. Increase of intraocular pressure is glaucoma or cataract. It is glaucoma. Okay, and then uh, astigmatism or nearsightedness. Which one has uneven corneal surface? Uneven corneal surface. It is astigmatism. Sympathetic drive to the pupils is constrict or dilate. Sympathetic constricts, huh? I'm sorry, ooh, my mistake. It actually dilates. Sympathetic dilates. You want to see the enemy, you want to see what's happening. Parasympathetic constricts. There you go. All right. Constriction, is it contraction of the circular muscles or the longitudinal muscles of the iris? Constriction, pupillary constriction. It is contraction of the circular muscles, pulling the edges more closer, resulting in constriction. Okay, huh? Which is the vitreous humor? Is it found in the area of the retina or in the area of the anterior chamber? Vitreous humor in the area of the retina. Aqueous humor is the one that occupies the anterior and posterior chambers. Okay. Where does the fluid uh, get access into the anterior chamber? Through the iris or through the pupil? Okay, it is through the pupil. Okay, right. The focus of the vision is on the optic disc or in the fovea centralis. Fovea centralis. Fuzziness on the center, clear on the side is a manifestation of glaucoma or macular degeneration. Fuzziness on the center is macular degeneration. Glaucoma is fuzziness on the outside, clear on the center, the opposite. Okay. All right. Tell me if it's oculomotor, abducens, or trochlear nerve. I'll say lateral rectus. Is it oculomotor, abducens, or trochlear nerve? Lateral rectus is abducens nerve. Inferior rectus, it is by oculomotor nerve. Medial rectus, it's by oculomotor nerve. And how about your superior oblique? Is it abducens, trochlear, or oculomotor nerve? Yes, it's by trochlear nerve. Okay. Where does the lacrimal fluid uh, drain into? Superior, middle, or inferior meatus? It will be draining into the inferior meatus. Okay. Inflammation of the conjunctiva, conjunctivitis, inflammation of the sclera, scleritis. Okay. Sense of smell uses the odorant binding protein hydrophilic or hydrophobic elements. Uses odorant binding protein hydrophobic. Okay. What cranial nerve fulfills the sense of smell? One, two, or three? Cranial nerve number one, olfactory. Okay. Sense of smell, which receptor is for taste? Filiform or circumvallate? Filiform or circumvallate? It is circumvallate. Okay. Um, sense of taste. Sense of balance. Which one is for horizontal movement? Is it macula saculi or macula utriculi? It's macula utriculi. Vertical movement is the saculi. Huh? Vertical movement, is it linear or rotational equilibrium? Linear or rotational? It is linear. Now, both of this, is it static or dynamic? Static is stationary. They're both dynamic. Huh? This linear and angular acceleration are dynamic. Okay. Sense of hearing. Tell me if it's part of the middle ear, internal ear, inner ear, or outer ear. Huh? I'll say auditory canal. Is it outer, middle, or inner ear? It is outer ear. I'll say helix. It is outer ear. How about your labyrinth? Outer, middle, or inner ear? It is inner ear. How about your incus? Okay, incus is middle ear. Okay, see? Which one is related to the oval window? Is it stapes or stapes or your uh, malleus? Oval window, you are related to the stapes. Okay, malleus is related to the tympanic membrane. Cerumen, is it found in the inner ear, middle ear, or outer ear? It's found in the outer ear, huh? Outer ear. Uh, how about your how about your conduction or sensory neural deafness? Conduction or sensory neural deafness. If it is damage to the cochlea, it is sensory neural deafness. Anytime it's beyond the oval window. It's sensory neural deafness. Huh? So damage to the auditory canal, then it would be conduction deafness. Huh? Conduction deafness. Damage to the malleus, incus, and stapes. If they fuse together, then it would result in conduction deafness. And by the way, fusing together, that's a condition called otosclerosis. What are the two tests using the tuning fork? Two tests using the tuning fork is Weber's and Rini's test. Which one is put on top of the forehead? Weber's test, huh? Weber's test. Okay. Uh, the Eustachian tube or auditory tube, if it's more horizontal, is it in children or in adults? Eustachian tube, auditory tube, more horizontal, it is in adults, huh? No, I'm sorry. More horizontal is in children. Adults are more vertical. Okay. Um, the tragus is part of the inner ear, middle ear, or outer ear. Tragus is part of the inner ear, middle ear, or outer ear. It's part of the outer ear. True or false? Cerumen is not normally found in the ear. Cerumen is not normally found in the ear is false, huh? Cerumen is normal in the outer ear, in the auditory canal or ear canal. Inflammation, otitis interna is middle ear, inner ear, or outer ear. It is inner ear, otitis interna. Middle ear is otitis media, and outer ear is otitis externa. Okay. Let's go to taste. By the way, what's the receptor for the semicircular canals? Is it utriculi or crista ampularis? Utriculi or crista ampularis? It is crista ampularis. Okay. Now let's go to taste. Where is salty taste found? Is it the tip, sides, or posterior part of the tongue? Salty taste. It's more in the sides. Okay. Where is bitterness mostly found? Posterior part. Okay, which one is responsible for the anterior two-thirds of the tongue? Glossopharyngeal or facial nerve? Anterior two-thirds is facial nerve. Glossopharyngeal posterior one-third, huh, which is responsible for the gag reflex. Sensory, not taste, is by hypoglossal or trigeminal nerve. Hypoglossal and trigeminal, it is trigeminal. So again, in the tongue, remember, sensation by touch is trigeminal. Taste is facial for the anterior two-thirds. Glossopharyngeal for the posterior one-third. And movement is by the hypoglossal nerve. Now, for the corneal reflex, remember that sensation over the cornea is by trigeminal. Your closure of the eyelids is the facial nerve, and opening it up is by the oculomotor nerve. Okay? All right. Now, receptors like thermoreceptors, mechanoreceptors, nociceptor, is it by origin or by modality? Origin or modality? It is by modality. Proprioceptors, interoreceptor, exteroreceptor? Is it by origin or modality? It is by modality. See, huh? I'm sorry. If it's interoreceptor, extero, and proprioceptor, it is by origin. My bad on that, huh? Is it by? It's by origin. Okay, huh? uh, pain from the lung, let's say lung or the heart, is it by uh, origin or by modality? If it's an inside, then it's interoreceptor, it's by origin. Okay. What is the neurotransmitter for pain? Neurotransmitter for pain, okay, is neurotransmitter for pain is by your substance P, huh? Substance P, okay? Substance P, which is your neurotransmitter for pain, is actually picked up by your nociceptors. What part of the what formation in the brain is responsible for modulating pain? It is the reticular formation. Reticular formation. Now, which one which one of the receptors makes you adapt to the sensation faster and make you feel that there's no more sensation? Is it phasic or tonic? Adapts faster. Is it phasic or tonic? It is phasic receptors, and the tonic makes you adapt longer. So when you don't feel it anymore, your phasic receptors have been stimulated. Okay, which one is a unencapsulated versus encapsulated, huh? Unencapsulated versus encapsulated. Free nerve endings. Is it unencapsulated or encapsulated? Free nerve endings are unencapsulated. Okay, huh? Free nerve endings. All right. I think that kind of wraps it up. Okay. That's our chapter 16, which is about the general senses and the special senses. Right? You can go to your workbooks if you have workbooks and practice on that. You can go to your Connect at this point and also look into the chapter 16 there, get you some more training. Tomorrow we will have the week two lab available, and that will cover chapter 16 and also I believe it is tomorrow's lecture will be on respiratory system. So that will cover chapter 16 and the respiratory system. You can go ahead and look into APR, Anatomy and Physiology Revealed, for the respiratory system as well if you want, huh? Don't forget our assignments. It's about illustrating the respiratory system and also the heart. You can start doing that. And like we said, early submission of that can give you 5 percentage points for the weekly exam because a weekly lab quiz because it's also a lab exercise. All right, thank you so much, and keep on reading. It will complement our lecture today. I will see you tomorrow for the respiratory system lecture. Thank you.